So this was around 18, and rash that runs 4 limbs for 4 weeks duration. So before being period of motion, any complications. And left shoulder with pain progress into right shoulder and then involving both knees, ankles, and these were all inflammatory in nature clinical. So at the general practitioner, he was started on 15 milligrams of prednisolone, but into his 2 weeks of illness, he was increased to 40 milligrams. So there was initially some help, but the joint swelling was progressing, and the swelling was extending to his forearms, calves, and there was extensive swelling ultimately. So he had intermittent fever, night sweats, loss of weight of more than 4 kilograms, and skin rash in both lower limbs. So in his past history, and about July 2012, about 6 years back, he had a similar episode where there was a skin rash, fever, night sweats, arthritis, and a myalgia. And at that time, the ASOT titer was high, 1600, which was rising titers. However, the serial echocardiograms didn't reveal any carditis. And the cardiac MRI was also normal. A skin biopsy was done at that time, which revealed paniculitis. The CT angiogram was normal. He was treated with prednisolone again, and however, the symptoms didn't completely resolve. And then after about 6 months, he was readmitted and then started back on high dose of steroids. At this time, they were thinking a possibility of ANCA negative vasculitis and was started on azathioprine. So for this strategy, he responded well. However, he stopped treatment and then defaulted to follow-up. So on examination, there was tender erythematous swelling in both hands, extending to forearms. The swellings were quite extensive, but there was no evidence of compartment syndrome. Actually, the initial presentation, the surgeons were also involved because everyone was worried whether there was impending compartment syndrome. The knees and ankles revealed active clinical synovitis. And so this is how it looked like. Actually, these are similar pictures taken from the internet, but these were grossly swollen. And the upper limbs, they were extending up to the forearms. And there was skin rashes in both lower limbs, which was erythematous and nodular. And there was a prominent below with the left surrounding rim of erythema, and how it looked like. So the investigations, the CRP was very high, 466, ESR was elevated, as well as cell count with a predominance. However, the procalcitonin was negative. The ASO titer was high again, and the anti-DNase B was raised as well, which is more specific for streptococcal infection. The CPK was normal. The liver functions were abnormal. CO and ECG were normal. The blood cultures, urine cultures were repeatedly negative. Hepatitis B, BC, Induction, and HIV, TB negative. The anti-CCP blood factor ANA were again negative. The complements were normal, and the urine was normal as well. So up to this point, we had no clue what was causing these symptoms, signs. The CT angiogram of renal and renal vessels were also normal. We've done an MRI scan of hand and forearms, which showed diffuse soft tissue swelling, but no evidence of synovitis. So the skin biopsy activity gave, so it revealed a necrotizing vasculitis involving small and medium arteries. The dermis was acute fibroid and depressor. there was the pancreatitis pattern also. So biopsy so the diagnosis the category of side so through the present unexplained loss of weight of more than 4 kilograms, libido reticularis, testicular pain or tenderness, myalgias, mononeuropathy or polyneuropathy, and then new onset blood pressure of more than 90. And about necrotic inflammation, small arteries without glomerulonephritis or vasculitis in arterioles, capillaries or veins. So capillaries and venules are not involved in polyarteritis nodosa. So these both these classification criteria are not diagnostic criteria. So they are used to inform or record or classify these diagnoses. So the polyarteritis nodosa still remains a clinical diagnosis, and we have to exclude the mimicking other vasculitis as well and other diseases. So there was a question whether this could be just a cutaneous polyarteritis nodosa or systemic nodosa. So the differentiation is when there is a major organ involvement, so systemic polyarteritis nodosa, such as the gastrointestinal, neurologic, or renal manifestations. However, the problem is in cutaneous polyarteritis nodosa, more than 60% of patients present with systemic symptoms. Apart from the cutaneous symptoms, we can have fever, arthralgia, myalgia, and neuropathy. So when these are present, it is going to be difficult to differentiate whether this is just a cutaneous PAN or a systemic PAN. And then systemic PAN otherwise will present with, typically presents with the systemic symptoms of fever, fatigue, weight loss, arthralgias in every patient. So the things to differentiate is from a Japanese study, they have found that when there is muscle and nerve symptoms in cutaneous PAN, they are secondary to focal skin damage and should be localized to areas of skin lesions. So true cases of cutaneous PAN will not have visceral manifestations or vasculitis involving muscle or nerve symptoms separate from the skin lesions. So in our patient, he had muscle symptoms, not limitation. So he's having a systemic PAN more than cutaneous PAN. So actually, the incidence of progression from cutaneous PAN to systemic PAN is unclear. So some studies say there could be so 10%. One study there's 10, but 3 cases found that there's that no one developed systemic PAN. So this could be either diagnosis not correct, they couldn't differentiate systemic PAN set. It is to systemic PAN because close monitoring is required because they can develop major involvement and life-threatening complications. So there's a proposed criteria, so which includes you can have so the typical skin lesions, have them with the biopsy findings of medium-sized artery involvement, and then the exclusion criteria is having fever 38 for more 2 weeks, hypertension, so the organ involvement, and the what we mentioned, so arthralgia or myalgia remote from the lesions, and also neurological symptoms remote from skin lesions. So when we consider all these, so our patient probably fit into a system which has no organ involvement. So the management, so we initially treated for infection with antibiotics with no response. So, and when the biopsy results were available, it was started on methylprednisolone 500 milligrams. And the following day, he had a dramatic response. So this was continued with oral inflammation. Following prednisolone tapering, isotapine was added because he had initially improved as well during his last episode. And then into 3 months of his illness, symptoms were completely improved. So what was fair amount of subcutaneous tissue leads to false negative results. So if you have the clinical suspicion is high, so and the biopsy is non-diagnostic, it's always better to repeat it. So the other factors affecting the findings of the biopsy sample is you have to have adequate size and adequate depth because the vessels that are involved is in the deep dermis or the subcutaneous tissue. So the biopsy should be, the skin biopsy should be deep enough and should have an adequate sample. So other things when considering the biopsy site is the results would be better if it's a fresh or new vasculitic lesion, and if it is centered over a tender nodule or purpuric lesion. And if you are biopsying an ulcer, the central part of the ulcer should be sampled along with the adjacent ulcer border and normal skin. So then only you will get a good biopsy sample to diagnose polyarteritis nodosa. So why we call it a rare cause? So limb swelling is known to occur, but this is usually the lower limbs. And upper limb swelling is rare, and especially extensive swelling. So I couldn't find any case reports regarding upper limb swelling for polyarteritis nodosa. So I would describe a little about polyarteritis nodosa. So it's a systemic necrotizing vasculitis that affects medium muscular arteries with occasional involvement of small muscular arteries. And ANCA is negative, and so it can affect virtually any organ, but there's a striking tendency to spare the lungs. So most cases are idiopathic. Secondary PAN can be due to B, C, hair cell. However, the pathogenesis is poorly understood. So regardless of the underlying cause, established PAN is characterized by segmental transmural inflammation of muscular arteries. So it does not involve the veins in other forms of where as well, this leads to ischemia or infarction. And also weakening of the vessels can lead to aneurysms, which can then rupture and then cause then mutilation as peak 6K. This can occur in children as well. And it's slightly more in the males, 1.5 to 1 ratio. Systemic valve, and then the skin lesions, it will have skin lesions, hypertension, renal insufficiency, neurological dysfunction, and abdominal pain. So, a little about skin disease. So it can present as erythematous nodules, like in our patient, and then can have purpura, reticularis, ulcers, bullous, or vesicular eruptions. rashes could be focal or diffuse. Usually it's more in the lower limbs, and lymphedema can happen in the lower limbs. Infarction and gangrene of fingers, toes could also occur with ulceration as well. So kidney disease presents with variable degrees of renal insufficiency. Rupture of a renal aneurysm can cause a perirenal hematoma, and then multiple infarctions can also occur. So hypertension is from renal ischemia leading to activation of renin-angiotensin system. So neurological disease, you can have mononeuropathy multiplex, and in 70% of patients, both motor and sensory deficits can occur. So usually it's asymmetric, but with more nerve branch involvement, it can be confluent, and it can present as a distal symmetric polyneuropathy as well. CNS involvement is only 5 to 10%. So gastrointestinal disease, so abdominal pain is the early symptom in mesenteric arteritis. It can be intermittent, continuous, or more prominent after meal, suggesting of an intestinal angina. And then it can have all the symptoms of GI involvement, such as nausea, vomiting, melena, GI bleeding. And can also have bowel perforation and infarction. It can also manifest as acute cholecystitis, appendicitis, pancreatic infarction, necrotizing pancreatitis as well. So regarding colonoscopy in a patient with the PAN, so perforation is more frequent. So if it's otherwise indicated, so minimal insufflation should be used. And if an ischemic error is seen, you have to terminate the study. So coronary artery involvement is known to occur. However, infarction is uncommon. Heart failure could be due to ischemic cardiomyopathy, or from uncontrolled hypertension. So, there could be bronchial artery involvement. However, lung parenchymal or capillaritis does not occur. And if they are there, then we should think of other diseases such as small vessel vasculitis. So muscle involvement is common, myalgia and muscle weakness. However, CPK can be elevated, but it is not high enough to suspect a myositis. So other manifestations are testicular tenderness, the classical features, and then retinal involvement can occur as well with optic neuropathy, and then breast, uterine, and splenic involvement can. So for diagnosis, there's no specific blood test. Because of the rarity of the disease and then the potential of severity of adverse effects of the treatment that is required during PAN. So as always, it's better to do a biopsy whenever possible. And so if you can't do a biopsy, then the alternative diagnostic tool is a arteriogram. So in the biopsy, you will find a transmural inflammation of muscular arteries. It doesn't involve the veins. So there would be polymorphonuclear leukocytes, mononuclear cells, or leukocytoclasts as well. And then you can see fibronecrosis involving the vessel wall. So granulomatous inflammation does not occur in PAN, and if it's present, you should consider other diagnosis. So this is a renal arteriogram. So this could be a diagnostic test. What are we looking for here are multiple aneurysms and irregular constrictions. So small arrows being multiple, and long arrow shows the occlusion of a small penetrating artery. Little about cutaneous polyarteritis nodosa. So this is a skin-limited vasculitis affecting medium-sized arteries. So it closely resembles classic systemic PAN with the cutaneous presentation, but doesn't have any visceral involvement. Patients may also develop mild systemic symptoms, which I described above. So most cases are idiopathic, but in 40%, secondary cause could be found, such as group A streptococcus infection, hepatitis B, C infections, lymph tract infections, parvovirus B19, tuberculosis, inflammatory bowel disease, and minocycline as well. So when there is association of cPAN with streptococcal infection, so the role of antibiotic therapy is unclear, so there's no enough data to recommend any recommendation. However, the active streptococcal infections are treated, but there is no data to suggest treating routine prophylaxis following treatment. So regarding management of Polyarteritis nodosa, so it is divided into mild disease and moderate to severe disease. So this is like our patient having no major involvement. So the initial treatment for such patients is glucocorticoid monotherapy without any immunosuppressive medication. So the usual dose is 1 milligram per kilogram, typically given for 4 weeks. And then if there is significant improvement, you can tail off the drugs, and usually given for up to 6 to 8 months. So this is the same approach given to isolated cutaneous PAN. If it's resistant, such only steroids or reduce the dose before below 10 milligrams. If there is side effect for steroids, so what they suggest is to give azathioprine or methotrexate rather than cyclophosphamide. Regarding moderate to severe disease, so this is when there is major organ involvement. So in this case, we have to treat with both glucocorticoids and cyclophosphamide rather than glucose alone. So the dose again, so for non-life-threatening conditions, is 1 milligram per kilogram to a maximum of 60 to 80. But if there's life-threatening conditions or a worsening mononeuritis multiplex, IV methylprednisolone is given up to 3 days, followed by oral prednisolone. So initially, it's given up to 2 to 4 weeks until significant improvement is observed. So then the dose is tapered and overall given up to 6 to 8 months. So there are two regimes of cyclophosphamide. So the cyclophosphamide IV pulse therapy given at 600 milligrams per square meter every 2 weeks for 3 doses. And then you can give 4 weeks or until every 4 weeks, 4 months until stable remission, and not for more than 12 months. Or else you can use the Cyclops regime of IV cyclophosphamide, 15 milligram per kilogram at week 0, 2, and 4, and then every 3 weeks. So if there's resistance to cyclophosphamide, if there's no response, the other options that can be given are azathioprine, methotrexate, or mycophenolate. And there are no studies to compare which are superior to each other. And then rituximab, there are case series where rituximab is given to treat PAN. So this is especially when it's non-HBV associated. So this is given after trying cyclophosphamide and at least one of the above oral drugs. There are a few case reports of using anti-TNF alpha agents, tocilizumab and tocilizumab as well. So the maintenance of PAN, so if disease was controlled with cyclophosphamide, we convert into either azathioprine or methotrexate. So usually, if in remission, treatment is continued for about 18 months. So when infection is associated, when we have a cause such as HBV or HPV, if it's mild PAN, so initial treatment is with antivirals rather than using immunosuppressive medications. If it's severe PAN, then we treat with initially we treat with glucocorticoids or plasma exchange until antiviral therapy is effective. However, there is no randomized trials to guide these decisions. But when there is inadequate response to antivirals, or if they are intolerant, then we treat as they were having no infection, like the regime that I described above. So monitoring, so once in remission for 2 years, if it's remission for 2 years, then you can reduce the frequency of review like every 6 months. After 2 years of remission, so all patients should be followed indefinitely because they can relapse again. So you can decide on whether every 6 to 12 months to review the patient. So, so the review should include a review of the symptoms of PAN, signs of PAN, and then including the blood pressure, looking for drug toxicities, and serum creatinine and the urine analysis. So these are my references. Thank you very much.
That's a very interesting presentation. Pasindu, I asked a question. So the liver function alteration, is it explained in cutaneous PAN? Another thing is, what are the characteristics of fever in cutaneous? So you mentioned about some Japanese guideline. So, hello.
The Japanese, so when to include that is the fever should be not persistent fever for more than 38 weeks. Sorry, Celsius fever. If it is there, then you should. It is more likely of systemic PAN.
For how long was the fever in this patient?
So this is more than 4 weeks.
Okay, right. So is it possible so this patient to have cutaneous PAN or polyarteritis both?
So this. So yeah, so this patient, so the criteria that I have given says that if there is more than 2 weeks of fever, is and conditions. So those is we thought is systemic PAN. So if it is cutaneous PAN, the muscle symptoms should be localized to the skin areas. But this patient had generalized muscle symptoms.
This is a male patient. Is it male patient?
Yes, male patient.
Is polyarteritis nodosa also preceded by streptococcal infections? Is there non-association with but cutaneous PAN there is association?
So yeah, so that's a bit of a controversial point. So here, someone can argue this could be a cutaneous PAN because it was as probable association with streptococcal infection. So this could be like a borderline one. So that's why we use some criteria. So try to to which one this falls. But I agree with, so this one it could be even a cutaneous PAN because it was there's association found, or even this could be probably one of the rare cases where PAN was associated with systemic PAN, the streptococcal infection.
Okay, thank you very much, Pasindu, for this interesting presentation. So I would like to thank everybody, the speakers and the participants for participating in this forum. Thank you very much. And we will meet next in 2nd of July with the monthly clinical meeting of CHRRSA. Thank you.